Working with the conoid and trapezoid ligaments are important in treating shoulder injuries because they do have referral patterns that refer pain through the anterior shoulder, through the deltoid, and in through anterior or the front of through the front of the chest. Now, working with conoid and trapezoid ligaments, they do have a ligamento-muscular reflex that is connected to pec minor, short head biceps, coracobrachialis. I've even seen it as far as being connected to subclavius musculature and even having an effect of increasing cervical spine active and passive ranges of motion after working with these structures. Now, working with these structures can be quite challenging in that you need to be able to locate them first. So I need you to be able to palpate the medial portion of the clavicle, slowly work laterally or distally out to the end. Now, this is where it gets a little confusing because the coracoid process of the scapula can sometimes sit in a very elevated fashion so that it feels like there's no separation between the coracoid process and the clavicle. Some people also become confused about if they're on the clavicle or if they're on the coracoid process or if they're on the head of the humerus. Now, to differentiate between those structures, what we're going to do is just take our patient's arm and we're going to externally rotate it. As we do that, we can see that my index finger starts to move. I know that I'm on the head of the humerus. I don't want to be in the head of the humerus, so I'm going to move a little bit more medially, and if I move her humerus into an internal-external range of motion and I'm palpating an osseous structure that doesn't move, I know that I'm on the coracoid process. So coracoid process and clavicle, there should be space for that conoid and trapezoid ligament to live nicely in. And with her, there's a little bit of space, but I think there could be a little bit more space, a little bit more elasticity in those tissues to function a little bit more efficiently. Now, with these tissues being involved in shoulder injuries, what we can do is we can take advantage of the pec minor musculature where it attaches onto the coracoid process, because we can get our patients to gently engage pec minor, which will then take the coracoid process inferiorly away from the clavicle, increasing the space for that conoid and trapezoid ligamentous tissue to live in. And with my left hand, I can load that coracoid process inferiorly, again, increasing the space and the length of those tissues to function in, working with the mechanoreceptors that are in the ligamentous tissue and taking advantage of that ligamental musculature or ligamentomuscular reflex. Then we can really create a change, a nice change in the environment and getting these tissues to function a lot more efficiently. So now that I've located very specifically and very precisely the structures that I need to focus on, I've got clavicle, I've got coracoid process, and in between the clavicle and the coracoid process, I have my conoid and trapezoid ligamentous tissue. I'm going to come onto my patient's pec minor musculature. I'm going to get you just to roll your shoulder down a little bit. As they roll their shoulder down, they engage pec minor. I can feel coracoid process immediately start to move in an inferior fashion. I can take my index and my third finger. I can load down towards the table and inferiorly towards her calcaneus. Remember that we're working with the mechanoreceptors of this ligamentous tissue. We're working with the ligamentomuscular reflex. We're disengaging those tissues from the dysfunctional holding pattern. We're engaging and exaggerating those tissues. As a balance occurs in the tissues, there's a softening and a decreasing in densification of the tissue, an increase in elasticity of the tissue. Just engage pec minor a little bit more. Pec minors engage a little bit more. Coracoid process is drawn a little bit more inferiorly. I've got more space for my fingers to fit into. I'm still loading down towards the table and inferiorly. If I get her to just to relax now, the space stays. I've matched the reciprocal tension of the tissues. I haven't loaded through the barrier. We're just waiting for a softening and a general change in the environment to take place. Now it's gotten to the point where everything feels nice and soft. Increased elasticity, densification of the tissue has decreased. I'm going to come back out. We'll have her take a deep breath in and a deep breath out. Just to reset the tissue, I will load my fingers back into that conoid and trapezoid ligamentous tissue, and it's a lot softer, there's a lot more elasticity, a decrease in densification of the tissue, and an increased space between that coracoid process and the clavicle. So that is how we treat the conoid and trapezoid ligamentous tissue for the shoulder.